Every morning, somewhere in this country, a senior sits down at the kitchen table, wraps a cuff around their arm, presses a button, and writes a number in a notebook. That number will go to their doctor. Their doctor will use it to make decisions about their medication, whether to increase the dose, whether to add a second drug, whether the current treatment is working. And there's a very real chance that the number recorded in that notebook is not an accurate reflection of what is actually happening inside that person's cardiovascular system. Not because the monitor is broken, not because the senior is careless, because nobody ever sat down and explained the difference between pressing a button and measuring blood pressure correctly. And those two things are not the same. I'm Dr. Eleanor Bennett. Subscribe to this channel before we go any further, because what I'm about to tell you is the kind of guidance that should be delivered the moment a blood pressure monitor is purchased, and almost never is. The result is years of readings that feel precise because they come with a number, and that fail to be accurate because the conditions producing that number were never properly controlled. Let me start with something that reframes this entire conversation. A blood pressure reading is not a fixed property of your body that exists independently of how and when it is measured. Blood pressure is a dynamic, continuously changing value that responds to your posture, your recent activity, your emotional state, your caffeine intake, the temperature of the room, whether you have spoken in the last 2 minutes, whether your bladder is full, and dozens of other variables that most people never consider when they reach for the cuff. When a physician takes a blood pressure reading under controlled clinical conditions, seated, rested, quiet, supported, correct position, they are attempting to minimize all of those variables in order to obtain a stable, reproducible number that reflects underlying cardiovascular status, rather than the noise of the moment. When a senior takes a reading at home, after walking from the bedroom to the kitchen, after their first cup of coffee, while still talking to their spouse, with their arm unsupported on the table and their back unsupported in the chair, they are measuring a completely different thing and calling it the same number. That gap between what a correctly taken reading tells you and what a carelessly taken reading tells you can be 10, 15, 20 millimeters of mercury or more, enough to influence whether a medication dose is increased, enough to suggest a hypertensive crisis when blood pressure is actually controlled, enough to provide false reassurance when blood pressure is actually elevated, and enough, accumulated over months of consistent measurement error, to paint a clinical picture that leads to medication decisions that do not match the actual underlying reality. Let me tell you about Walter, because Walter represents something I see in clinic with a frequency that troubles me. Walter was 71, diligent, organized, the kind of patient who never missed a reading. He had been monitoring his blood pressure at home for 3 years and recording every number in a logbook that he brought to every appointment. His readings were consistently in a range that his doctor found concerning, not dramatically elevated, but persistently higher than the target his medication was designed to achieve. His dose had been increased twice. He had added a second medication. The numbers had improved slightly, but remained inconsistent. Everyone was puzzled. When I asked Walter to demonstrate how he took his readings, the puzzle dissolved immediately. He took them at the kitchen table on a wooden chair with no back support, with his arm resting on the table surface but unsupported at elbow level. He had taken his morning coffee 40 minutes earlier. He had walked from the bedroom to the kitchen before sitting. He had been talking when he pressed the button telling me about his morning, and he crossed his legs as he settled into the chair, which he did automatically and had never been told mattered. Every single one of those conditions was adding pressure to his reading. The unsupported arm alone can add 6 to 10 points. The crossed legs can add 2 to 8 points. The recent coffee, the recent walking, the talking, each contributes its own increment. Walter had not been measuring his blood pressure for 3 years. He had been measuring the blood pressure of a man sitting incorrectly, recently caffeinated, recently active, mid-conversation, with his legs crossed. That person's blood pressure was higher than Walter's actual resting pressure, and 2 medication adjustments had been made on the basis of those numbers. So let me go through each variable precisely, because this is not abstract physiology. These are specific, correctable errors that change numbers in specific, measurable ways. The arm position. The cuff must sit on a bare arm at heart level, approximately the level of the mid-sternum. If the arm is below heart level, gravity adds points to the reading. If it is above, the reading drops artificially. The arm must be fully supported along its entire length, not just at the wrist. An unsupported arm requires muscular effort. That effort raises pressure. That pressure goes into the number. The seated position. Back fully supported, not leaning forward, not perching, feet flat on the floor, legs uncrossed. Crossed legs increase peripheral vascular resistance. The reading goes up. These are not minor stylistic preferences. They have documented measurable effects on the numbers produced. The rest period. 5 full minutes of seated quiet before pressing the button. Not 60 seconds. Not a few minutes. 5. Blood pressure stabilizes slowly after movement, emotion, or activity. Most seniors sit down, wrap the cuff, and press the button within 60 seconds of arriving at the chair. The reading they record is not their resting blood pressure. It is their transitioning blood pressure, a number from a body that has not yet settled. The timing of caffeine, food, and activity. Caffeine raises blood pressure for up to several hours. Exercise elevates it for 30 minutes or more after stopping. A large meal affects it significantly in seniors. The standard recommendation is to avoid caffeine, food, and exercise for at least 30 minutes before measuring, which means the morning reading should come before coffee and before breakfast. Most seniors do the opposite, because nobody told them this mattered. Talking and emotional state. Blood pressure rises during conversation. It rises during anxiety, stress, or anticipation of the reading itself. A senior talking to their spouse while the cuff inflates is measuring a conversation, not a cardiovascular baseline. Take readings in silence, never while distracted, and take 2 or 3 in sequence. The first is often elevated by the alerting response, and the average of the stable readings that follow is the number worth recording. Let me tell you about something that almost nobody considers when they buy a blood pressure monitor, and that silently corrupts every reading from the first day. The monitor itself. Not all blood pressure monitors are accurate. Not all wrist monitors are reliable. Not all devices sold in pharmacies and online have been independently validated against clinical standards. A monitor that displays confident, precise-looking numbers can be systematically reading 6, 8, or even 12 points higher or lower than the true value, and the person using it will have no way of knowing, because the number comes out with the same apparent certainty regardless of whether the device is accurate. Wrist monitors deserve particular caution. They are convenient, they are popular, and they are significantly more sensitive to positioning errors than upper arm monitors because the wrist must be held at exactly heart level for an accurate reading, a requirement that is almost impossible to meet consistently without careful technique. Wrist monitors placed slightly below heart level read high. Placed slightly above, they read low. And the difference between those positions across the range of movement that occurs naturally during a measurement can be substantial. Upper arm monitors with validated cuffs, placed correctly, remain the standard for reliable home blood pressure monitoring. The monitor should be checked against a clinical device at least once brought to a doctor's appointment and compared against a reading taken with calibrated office equipment. If the home monitor reads consistently higher or lower than the clinical device by more than 5 points, the home monitor is not providing accurate data, and every reading from it is systematically biased. Patricia was 73 and had been using a wrist monitor for 4 years, one she had received as a gift from a popular brand, with a clear digital display and memory storage for her readings. Her numbers had been fluctuating in a way that concerned her doctor. 2 readings on the same morning could differ by 12 points with no obvious explanation. When she brought the wrist monitor to clinic and we compared it against the calibrated office equipment, the wrist device read 7 to 11 points higher across 3 consecutive measurements. 4 years of readings, all systematically elevated, all influencing clinical decisions, from a device that felt precise but was not accurate. The distinction between precision and accuracy matters enormously in blood pressure monitoring. Precision is getting the same number consistently. Accuracy is getting the right number. A broken clock is precise. It gives the same reading every time. It is not accurate. A wrist monitor that consistently reads high is precise. It is not accurate. And in medicine, accuracy is the only kind of precision that matters. Let me tell you about Eleanor. Eleanor was 68 and had been told her blood pressure was well controlled on her current medication. She monitored faithfully morning and evening, every day. But when she sat with me and we went through her readings systematically, a pattern emerged. Her evening readings were consistently lower than her morning readings by 15 to 20 points. Not a small difference. A clinically significant one. And when we traced the difference back to her routine, the explanation was clear. Her morning readings were taken immediately after waking before coffee, with adequate rest in a quiet room. Her evening readings were taken after dinner, after the evening news, after a glass of wine, while still in conversation with her husband. Her evening readings were therefore not comparable to her morning readings. They were measuring different states of being and reporting them as equivalent data points on the same chart. Eleanor's doctor had been averaging the morning and evening readings together to assess her medication's performance. But those 2 numbers came from such different conditions that averaging them produced a result that did not accurately represent either her true resting pressure or her medicated pressure. The clinical picture being used to manage her medication was built on a foundation of mixed incomparable data, and the medication decisions flowing from that data were less accurate than they needed to be. Now let me address something that applies specifically to seniors who are anxious about their readings, a pattern that produces systematically elevated numbers at home in exactly the same way it produces them in the doctor's office, and for exactly the same reason. Blood pressure rises in anticipation of its own measurement. This is a documented, reproducible physiological phenomenon. The moment a person sits down to measure their blood pressure, particularly if they are concerned about what the reading might show, the act of measuring triggers a mild stress response that elevates the very pressure they are trying to measure. In the clinical setting, this is called white coat hypertension. At home, the same effect occurs in people who have developed anxiety around their readings, who check their pressure repeatedly because they are worried, who feel their heart rate rise as they reach for the cuff, who hold their breath slightly as the cuff inflates, and then look at the number with dread. Diane was 67 and checked her blood pressure 4 to 6 times on mornings when she was worried. She would get a reading, feel alarmed by it, check again, feel more alarmed when the second reading was also elevated, check a third time, and so on, not realizing that each successive reading, taken in a state of increasing anxiety, was progressively less likely to reflect her true resting pressure, and more likely to reflect the anxiety of the measurement itself. She had pages of readings, taken in clusters, showing alarming numbers that resolved when she stopped measuring. which she sometimes did when she finally distracted herself enough for the anxiety to subside. The solution to modern anxiety is not more readings. It is fewer, better timed, properly conditioned readings. 1 or 2 per day, taken under controlled conditions, recorded without commentary, and reviewed weekly, rather than scrutinized moment by moment. The number is data. Data is most useful when collected calmly, consistently, and without emotional reactivity. Now let me tell you about the arm choice. Because most seniors are never told that the arm used for measurement can affect the reading, and the difference between arms is sometimes significant enough to matter clinically. Blood pressure can differ between the left and right arm. In most people, the difference is small 5 millimeters of mercury or less. But in some individuals, particularly those with arterial stiffness or vascular asymmetry, the difference can be 10 points or more. Using the arm with higher pressure consistently and using the arm with lower pressure at other times creates artificial variability that looks like blood pressure instability when it is actually measurement and consistency. The standard recommendation is to measure in both arms when first establishing home monitoring. Identify which arm produces the higher reading and use that arm consistently for all future measurements. This creates a reliable, comparable data set. Most seniors have never been told to do this. They use whichever arm is more convenient, or whichever arm the cuff fits more easily, or whichever arm happened to be used the first time and has been used by habit ever since. Leonard was 74 and had readings that puzzled his cardiologist with their variability. Good one day, elevated the next, without obvious pattern. When the arm variable was finally examined, the answer was immediate. Leonard's right arm consistently read 8 to 10 points higher than his left. He had been alternating arms based on nothing more than which side of the chair he was sitting closest to. His readings were not variable. His arm selection was variable, and that selection difference was being recorded as blood pressure variability and factored into medication decisions that did not need to be made. So what does correct home blood pressure monitoring actually look like? Let me give you the complete picture, not a simplified version, but the full protocol that produces numbers worth trusting. Choose a validated monitor with a properly sized cuff. A cuff that is too small reads high. A cuff that is too large reads low. The cuff bladder should encircle at least 80% of the upper arm. If you are unsure whether your cuff is the right size, ask your pharmacist or your doctor to check. Sit quietly for 5 full minutes before measuring. Feet flat on the floor. Back fully supported. Arms supported at heart level along its entire length. No talking, no phone, no television, no conversation. 5 minutes of genuine quiet. Measure before coffee, before food, before any physical activity, and before taking your morning medication. The reading taken before medication tells your doctor what your baseline pressure is before the drug acts. The reading taken consistently at the same time each day is more valuable than readings scattered across different times and conditions. Take 2 or 3 readings, 1 to 2 minutes apart, and record the average. Discard the first reading if it is notably higher than the subsequent ones. The alerting response is likely responsible. Always use the same arm. The arm with the higher reading, identified in the first week of monitoring consistently for all future measurements. Record the time, the arm used, and any relevant circumstances. If you had already had coffee, if you had been active, if you were anxious or unwell. Context transforms a number from a data point into a clinical story. Your doctor can use a number with context. A decontextualized number is only partially useful. Walter changed his technique. For the first time in 3 years, he took readings under controlled conditions, properly positioned, properly rested, appropriately timed. His new readings were lower than the old ones by an average of 14 points. His medication, recalibrated on the basis of accurate measurements, was adjusted downward. He did not need the dose increases that 3 years of incorrect readings had led to. He did not need the second medication that had been added, because the noisy numbers suggested inadequate control. He sat across from me after the first month of accurate monitoring and said something that stays with me. He said, "I spent 3 years thinking my blood pressure was harder to control than it is. I was just measuring it wrong the whole time." That sentence is why this video exists, because a monitor on a kitchen table, a cuff on an arm, and a number in a notebook feel like precision. They feel like certainty. They feel like data. And they are data, but only if the conditions producing them are correct. Otherwise, they are noise dressed as information, influencing decisions that deserve better. You have been doing this every day. Now you know how to do it right. Share this video with someone whose doctor has been making medication decisions based on home readings that may not have been taken correctly. Subscribe to this channel, and I will see you in the next video.